Now, is it a good idea to put a skin graft to prevent recurrence? That is the question that Dr. Francine Vos is going to answer for us.
Yes, thank you for the introduction. And thank you for the opportunity to share our experiences with dermofasciectomy and full-thickness skin grafting for severe or recurrent Dupuytren's disease. I'm Francine Vos, a doctor from UMC Groningen. These are our disclosures. So I'd like to present to you a case of ours, B. Joel, not a real name, but a real case, a 61-year-old piano teacher with progressive Dupuytren's disease. And after multiple treatments, we decided to perform a dermofasciectomy with a full-thickness skin graft. As the UMCG is a referral center for severe or recurrent cases of Dupuytren's contracture, it's an ideal setting to evaluate outcomes of standard care. So how are our patients doing? We included all dermofasciectomies with full-thickness skin grafting between 2006 and 2023, which were 117 patients. Of those, we did a medical record analysis of 141 rays. Additionally, to complement the data, we also invited them to our outpatient clinic to look at their current clinical status. We were able, of those 141 rays, to evaluate 99 rays and add that to our medical record analysis. As mentioned before during this Congress, definitions are of utmost importance. The following definitions we used for recurrence: the reappearance of Dupuytren tissue under the graft without an extension deficit, or an increase of total passive extension deficit of more than 30 degrees. These measurements were taken at 6 weeks postoperatively and at the latest follow-up time. Furthermore, we looked at complications and at patient satisfaction. So recurrence without an extension deficit of more than 30 degrees, but with the reappearance of Dupuytren tissue, we found 2 cases. Then the recurrence with an extension deficit. There are either 2 groups we made. One is without any reappearance of Dupuytren tissue, and the other with a reappearance of Dupuytren tissue. The first, with no Dupuytren tissue reappearance, the contracture was caused by a scar contracture or by joint stiffness. This was 7 cases. Furthermore, with the reappearance, it could either be under the graft in 3 cases, or distally or proximally from the graft in 1 and 3 cases. And we hypothesized that this might have been, we could have been prevented this if we would have taken a larger graft. And lastly, junctional reappearance in 8 cases. These are the numbers. And if we put all the numbers in one table, these are the numbers I just walked you through, with a total of 17% of recurrence, if you take all the definitions together. Interestingly about this table is that if we look at the medical data that is available only, we do not find any reoccurrence under the graft. This is in line with the literature, in which many retrospective literature reports a recurrence of under the graft of 0. But if we look cross-sectionally at the patients that we did invite, then we do find a reappearance under the graft. This highlights the need to see the patient, do a physical examination to find that subtle or early detection of Dupuytren recurrence. Short-term complications were manageable. None of these required a re-intervention. Cold intolerance was the most common long-term complaint, which is expected and should be discussed preoperatively. Loss of sensibility improved over time. From 10% in the short term, we found only 3 to 5% in the long term. So here I want to take you to a graph. On the y-axis, you see TPED change, which is the degree after surgery and at follow-up time. And on the y-axis, you see the time between the surgery and the follow-up time. The red line represents the progression over time. There is a correlation, but it is weak, but it is significant. So we stop the process, but we cannot always prevent the reoccurrence of the contracture. In this box, you see the TPED recurrences. We found a median time of 3.6 years. Interestingly, most patients show no deterioration in TPED over time. In fact, many even demonstrate an improvement. This likely reflects the positive impact of post-operative hand therapy in maintaining or even enhancing extension. Also interestingly, patient satisfaction remained high, even among those who had recurrence. This suggests that stability, even partial, and absence of repeated procedures contribute to more perceived success than the total contracture correction. Furthermore, we found a high willingness to undergo the treatment again, even in the recurrent cases. 3 takeaways from this analysis. First, we need clear definitions of recurrence and physical examination to assess. Second, cold intolerance was very common, but is expected with most hand surgeries. It is important to inform patients preoperatively. Satisfaction was high, but keep in mind that does not always reflect hand function. We initially included the Michigan Hand Questionnaire to assess function more objectively. However, many patients felt that it didn't reflect their actual hand function nor their daily challenges. As a result, the MHQ data proved to be uninformative in this context, and eventually we decided to discard it. This underscores the need for better, more tailored tools to assess the hand function. Back to our piano teacher. At 3.5 years post-op, he has maintained improved function. He's still playing piano, and this is not a rare outcome. He reflects the pattern we observe in many of our patients. Take-home message: a dermofasciectomy, in our experience, with full-thickness skin grafting shows a low recurrence, manageable complications with a high patient satisfaction, but future studies should include outpatient follow-up and standardized assessment of hand function. Thank you for your attention.
Thank you very much. A question? Just one question? No? Yeah?
Can you explain the rationale for using that definition for recurrence? Like, what's the point of making that cutoff? Like, if you have 19 degrees progression versus 21 degrees progression or 29 degrees, why don't you just say how many degrees you progressed instead of trying to dichotomize to I don't fully understand that.
Yeah, that's a good question. Thank you. I believe that I think that is why hand function is a way better tool to evaluate if the outcomes of the study. We can make a cutoff at any degree, but it's really about the hand function that really will say something about the outcome for the patient.
Not blaming you, but I'm seeing it most of the studies here that everybody wants to make a cutoff on a continuous scale, which is nonsense. There's no true cutoff in a continuous value. It's not your fault.
I agree, but since we have been using the third degree in earlier studies, we decided to use the same value just to be able to compare. But I absolutely agree that what is important is that
Yeah, I totally agree with you. That's why the graph is so interesting, where you can see the actual difference in recurrence instead of like the total number of 17% doesn't really give away how many patients. I think really the graph is what is interesting about this whole article. Thank you for your comments.
Okay, thank you very much. And